Hi, my name is Nicole Kupchik, and welcome to 10 Minute Tidbits. So I'm here, but I can't say that without laughing, so sorry. That's the name of my show, 10 Minute Tidbits. So, but anyway, I'm here today with Makayla I. So hi. A couple weeks ago, we posted a video on targeted temperature management after cardiac arrest. And we kind of just talked about the dose, either 33, 36, and maybe possibly there's a new study that's going to be evaluating 37 degrees. Now, what Makayla and I want to chat with you about is management of patients who are getting targeted temperature management. So, Makayla, just really quick, can you remind the audience about yourself?
Yeah. So I'm a nurse, a critical care nurse, and I'm actually just finishing up my PhD at the University of Washington, and I'm looking at patients after cardiac arrest, specifically who are getting targeted temperature management. And so really interested in kind of like how you manage those patients, what's the differences, what do you do when you're cooling them to 33 or 36, like, you know, at the bedside, how do you care for those patients with the best knowledge possible?
Yeah, Makayla, can you say it all, like a little, can you give them a little hint about what your dissertation's going to be about? Just a little tiny hint.
I'm looking at energy expenditure in patients who are being cooled, so how
Not a big deal, you guys, right?
No.
Trust me, it's a big deal.
How your metabolism changes, especially if you're cooled to 36. We don't really know a lot about how things like drugs, shivering, how all of those things change your metabolism when you're just 1 degree below normothermia.
Yeah, I mean, we do know that there are changes. We just don't know to what extent. So, okay, so let's chat now. Okay, so let's say we've got a patient who's being cooled. They had a VFib arrest. We're cooling them. Their temperature is 33 degrees. What are the big things clinically you watch out for?
I think the biggest thing to watch out for, of course, is shivering. So, you know, a lot of people say that you have that shivering threshold where once you get below about 33.5, 33.3, you kind of stop shivering and actually decrease shivering, but you can shiver the entire time. So really paying attention, especially during induction or rewarming, and particularly during rewarming.
And being aggressive with treating it, right?
And just being really thoughtful about assessing your patient frequently for shivering.
Let's really quick. Okay, so do you know where the best place to assess for shivering is?
Show me.
Well, so to be honest, we start with the jaw, right? So it's the jawline and kind of like more toward the core is where shivering will start. Now, if you're seeing a shiver response out in the periphery, that patient's pretty engaged in that shiver response. Like, what else would you add to that?
I look for any kind of pilar erection, so a little goosebumps on the skin, any little, like she said, into the jaw, the neck, and also the upper chest. Really pay attention to that. And also, some people can see really aggressive shivering and think maybe it's like some myoclonic jerking or seizure activity. So being able to, you know, try to differentiate those two if you have really severe shivering is important.
And that's challenging, to be quite frankly honest, to figure out, is it myoclonus or is it shivering? That can be so challenging. But this is where like EEGs and things like that can help you kind of differentiate.
Yeah, get your
shivering.
team involved.
Yeah, absolutely, for that one. Okay, now I said we're at 33 degrees. What do you worry about? You said shivering, but actually at 36 degrees, that's where patients shiver like mad.
Right.
Now, what are you saying? Because you've actually looked at data behind this.
You know, so you have a shiver threshold where your body likes to be at normothermia. It is one of your basic responses is to maintain your normal body temperature. So anytime we purposely change your body temperature, your body is fighting that. It naturally fights it. It should fight it. Yeah. Right? It's working
a normal
hard.
Response.
Yeah. And so even 1 degree colder at 36, you're right at that threshold where you start to shiver. And so patients really want to be warmer. We haven't got down to 33 where they're not going to shiver as much potentially. We're right in that shiver zone. Yeah. And so patients tend to shiver quite a bit. And so you can see it more throughout the entire, you know, TTM phase, induction, maintenance, and rewarming, and even further out.
This is at 36. Yeah. And so regardless if you're doing targeted temperature management, just so you guys know, that's the new name. So it's no longer therapeutic hypothermia. The name is targeted temperature management. But if you're doing TTM, you should have a shivering protocol, right?
Absolutely.
With medications you can use. So let's talk strategy. You've got someone who's shivering. What can we do to help to treat or prevent shivering? What do you think?
So for me, the number kind of one thing is to use your non-pharmacologic measures. So you can use counterwarming. Do you guys use counterwarming?
Absolutely. And you guys, this is really so easy. And a lot of people are afraid to do this, but if you're using catheters or if you're using like an external device like the Arctic Sun or something like that, what you can do is put a forced warm air blanket over the patient's skin to trick the thermoreceptors on the skin into thinking they're warm. And it's actually super, I don't know, I think it works.
Yeah, about 20+% of your shiver response comes from your skin. So if you trick the skin into saying that it's warm, your hypothalamus might say, I don't need to start shivering. Even covering the head, some people use mittens and blankets. You can use a warm blanket. It doesn't have to,
you know, forced warm air blanket. Yeah,
but that works, probably the best over time.
Like, what other non-pharmacologic measures would you do? That sounded so fancy. So what would you do?
Well, I don't know if I have any other ones. I think counterwarming's the big one.
Okay, so let's go into meds then.
Yeah. So another one that can be recommended for patients kind of prophylactically is Tylenol around the clock.
Absolutely.
A lot of people use that.
And would you use IV or down the feeding tube, or what would you do?
I think it depends on your organization and kind of what the flavor is. I don't know. What do you think?
I think IV. Your gut motility is completely slowed down, so I think IV is the way to go for this. So
and a lot of places also use buspirone, which has some anti-shivering properties. Again, with the GI absorption, you might have some difficulty kind of absorbing that, but it can be used as a prophylactic, and it's pretty harmless. But it can help lower that shiver threshold.
Okay, so we've got acetaminophen, buspirone or buspar. What else?
So that's kind of the preventative section. So a lot of people will kind of do those three things, counterwarming, and then give just scheduled other drugs. And then if your patient starts to shiver, then you can kind of move down, like you said, having an algorithm where if you're using a shiver scale or some sort of tool to measure shivering, then you can kind of link up your protocol with that shiver scale.
Yeah, so if we want to get really aggressive, now what can we do? Well, what some facilities are using, they're using magnesium actually pretty frequently. Do you use magnesium at your facility to treat shivering?
Yeah, and magnesium really relates to the ability of your muscles to contract. So if you have a higher magnesium, your muscles relax quite a bit, and so it actually helps a lot with shivering and keeping them even a little bit higher, not just 1.8 to 2, but like some institutions even go 2 to 3.
Yeah, and I teach in my CCRN classes, when the mag is high, you get the mag drag. And so anyway, but with high magnesium levels, the muscles are just really flaccid, and so can really help with shivering. All right, so let's get a little more aggressive. What else can we do?
So next steps, we can do a little bit more sedation.
Okay, we try some sedation, sure.
Yeah.
What
else would you do?
Well, I mean, I came from an institution that we were pretty aggressive, and we've used a lot of paralytics, just to be quite frankly honest, over the years. And in our kind of the model we had initially taken was let's just prevent shivering up front. Let's just be honest. If you use a neuromuscular blockade, you're not going to shiver. But one of the things we worry about is metabolism of the medication and how much do you use? Should you use lower doses? And then of course, and let's just be super clear: if you use a neuromuscular blockade, you better put a sedative on first, right?
Yes.
Okay, so always a sedative first, and then so then you're using a combination of sedative and neuromuscular blockade. So I don't know. I think the jury is really still out there as to what the best treatment plan is. But here's the deal: have a treatment plan for shivering.
Yeah. A lot of institutions also go back and forth between Demerol. So that comes into favor, comes out of favor. The worry that a lot of people think about is your risk for seizures.
Yeah, and I've heard some people say it's just completely bunk, and I've heard neurologists say that it decreases meperidine or Demerol, decreases the shiver threshold. But recently I'm hearing them say it's bunk. There's really very little evidence for that. So
I agree. Okay. A lot of people will give a lot of drug, a lot of meperidine, and nothing happens. So, but some institutions say yes, we use it. Some institutions don't include it. But
But I have a plan.
Yes, a plan.
Okay, so we talked about shivering. All right, now other issues with cooling.
Dun, dun, dun.
Electrolytes. Dun, dun, dun. So these patients get crazy hypokalemic, hypomagnesiemic when you take them down to 33. So tell us what your experience has been, just clinically and then from your research.
I think observationally, when you're taking care of a patient at the bedside, you see those electrolytes change because we're usually doing electrolytes every 4 hours, every 6 hours, and we know we're going to keep an eye on that K. Especially, the theory is that your potassium, when you get cold, moves from extracellular to intracellular, and then of course you're peeing a lot of it out because you get a lot more of diuresis from being so cold and other things. So partly you're peeing out your K and your MAG and your phos and all of that stuff, but also the thought is that your K moves intracellularly, so it's kind of still there, it's just not in the right place when you go to measure it with your labs.
So, but we should definitely, during the induction and maintenance phases, you should be replacing your electrolytes. However, once you start to rewarm, stop replacing because you can overshoot some of these patients. But so just be careful with it. But the big ones are MAG, K, and phos. Those would be the 3 big ones.
Yeah.
Anything else you'd add to that?
No.
Okay. All right. Next issue, bradycardia.
Oh no, I do still have an issue.
Oh wait, she does have an issue. Let's go back.
But more.
Let's hear it. She's got more.
Think about your patient at 36. So what we don't know is, do you have to replace potassium, magnesium, all of those things at 36?
Yeah. Well, you probably don't want them getting low, right? Just because of arrhythmias and things like that. But how aggressive do you have to be?
Do you have those intracellular shifts and urinary losses? Do you get autodiuresis when you're cold at 36?
Yeah, and I know one of the things we've seen clinically is not as much. Definitely not as much. You don't have as much electrolyte shifting and diuresis as you did with 33. So
yeah. So I definitely would keep an eye on that. And be looking for some papers that might be coming out, related to
some papers.
No.
Okay.
Anyone's papers. I don't know.
That, so, okay. All right.
What happens, and you might not have, like you said, you might not have all of those losses. So just be careful.
Yeah. Okay. All right. The next thing, bradycardia. Oh, this is scary, right? And I will never forget the very first patient we cooled way back in 2002. This guy's heart rate went down to like the high 20s, low 30s, and we were
us too.
And we were like, should we push atropine? Like, no. Actually, the blood pressure was fine because there's so much cold-induced vasoconstriction. And there's been newer data to show actually when patients are bradycardic, it's associated with better outcomes. So don't be afraid of the bradycardias as long as the patient's hemodynamically stable. Like, what's the lowest you've seen, Makayla? Because you guys 20s, yeah. And it's scary.
And the patient has normal blood pressure.
And the blood pressure's totally normal because there's so much vasoconstriction, right? They're peeing, they're fine, right? Yeah. But you're looking at the monitor going, whoa, it's scary. Yeah. But they actually
turn the heart rate limit down.
Yeah, just kidding. Just don't watch. No, watch. Please watch that. So, but doesn't seem to be like kind of the big bad scary thing we thought it was. So okay. Any other big things you'd worry about?
I think about bleeding risk. So
sure. Especially at 33, right?
Yeah. Okay. So just be looking out for some of that. Some institutions now are thinking about even scanning patients' heads. Doing a CT scan before. So if you find someone down on the ground, did they hit their head when they had their cardiac arrest? Yeah. Maybe they had a low intracranial bleed. So some kind
of figure out why they arrested.
So some people are calling it like the sudden death protocol, where they kind of run through like almost like your H's and T's during ACLS, like what causes cardiac arrest if you're not really sure.
Yeah. Okay. And then is there anything else we should talk about as far as management of these patients? Rewarm slow. Okay, we mentioned this in the last segment that we did together, but rewarm these patients slow. There's really good animal data to show when animals are rewarmed too quickly after they've received therapy that it's associated with worse neurologic outcomes. So most facilities are rewarming at 0.15 to 0.25 degrees per hour. So bring that patient up slow. Bring them, warm them up very slow. So
yeah, I agree with that.
Okay, anything else, Makayla?
No,
those are the big ones. Yeah. And then what we'll do is, so Makayla and I mentioned in our last segment that we're actually going to chilling at the beach in Miami. We're going to Miami. And so anyway, but what I would love to do is another segment on prognostication, because this is such a huge deal. Like, when do you discontinue care on these patients? And, it's been crazy, but I will never forget, we had this guy that woke up at day 13. His wife kind of kept talking us into, 3 more days. And at day 13, his eyes were like, bing! And he's like, where am I? It was, he didn't say where am I because he was intubated, but he was mouthing things to us. It was kind of crazy. So I would love for Makayla and I to talk about prognostication in our next segment. So if you have anything you want to know, let us know. So email me at Kupchik, Kupchik, at gmail.com, or find me on Facebook, Nicole Kupchik Consulting and Education, or on Instagram at Nicole Kupchik, and I'd be happy to answer any questions you've got. So, all right, any closing remarks, Makayla?
No.
But they should do this therapy, right?
You should do it and have a protocol and measure your outcomes.
Measure your outcomes. And she's a research guru, so she's saying measure the outcomes. But I agree. I totally agree with you. Yes. Okay. Well, thanks to everyone for tuning in. We love just having this little chat with you. So give us a thumbs up if you liked this on our YouTube channel. But we'll talk to you soon. Bye.